Welcome and thank you for being interested in this virtual presentation about the development and feasibility of the SOCAV in primary care program. This study, a design feasibility study, is based on a mixed method design. It has been split up into two phases of the MRC framework. Phase 1, the developmental phase, focuses on the question which elements could improve the likelihood of success of SOCAV in primary care. Phase 2, the feasibility and piloting phase, focuses on the question what is the feasibility of SOCAV in primary care. Results deriving from this study will be used in the feasibility effect study, which has recently started. SOCAV in primary care aims to support persons with dementia and their informal caregiver to maintain or improve their self-reliance, daily functioning in meaningful activities, and quality of life. It involves a longitudinal training and coaching to home care professionals. The training to home care professionals focuses on person-centered communication, observation skills, and reflection. Furthermore, it involves a coaching to home care professionals coached by a SOCAV coach to use the skills in practice and reflect on their own performance and behavior towards the person with dementia and their informal caregiver. This reflection on their own learning process is done by keeping a diary on a structured range of questions and having individual and group coaching. The training and coaching is based on the principles of the Community Occupational Therapy in Dementia program and on the Colorama Self-Management Training and Coaching Program for nurses. I would like to present the main results of the developmental phase deriving from focus groups and individual interviews with and face-to-face interviews with the person with dementia, informal caregivers, and home care professionals. We have found that informal caregivers experience a high burden in taking care of the person with dementia at home. Secondly, there is no alignment between the informal caregiver and the home care professionals about psychosocial support, because home care professionals are more used to work protocol-oriented. Third, the needs and wishes of the person with dementia are unexplored. And finally, the meaning of self-reliance is unclear to the informal caregivers and home care professionals. Based on the results of these focus groups and interviews, we concluded that it would be useful to create regular meetings between the person with dementia, the informal caregiver, and the home care professional, and focusing on their wishes and needs. Secondly, we provide a special training and coaching to the home care professionals in support and conversation with the person with dementia and the informal caregiver. In phase 2, the feasibility and piloting phase, findings were based on the experiences of a small group of participants of the pilot and interviews. Unfortunately, COVID-19 interrupted this phase. The piloting had to stop just after the first coaching conversations between the SOCAV coach and the home care professional. However, we had some findings in this phase. Face-to-face interviews were experienced as supportive for people with dementia and their informal caregivers, and more efficient than paper. SOCAV coaches experienced the individual coaching with the home care professionals as challenging. The home care professionals are unfamiliar with reflective coaching, and it's experienced as scary and confronting at the time. Despite COVID-19, we still have some recommendations for the upcoming feasibility effect study. Enhancing transparent communication between a small group of stakeholders were found to be important in primary care. Concluding, to support the reflection process and learning curve of the home care professionals, it's recommended to start earlier with the individual coaching and let the SOCAV coach be more visibly present. Thank you for listening, and if you have any questions, please don't hesitate to ask them.